Okay, so this is going to be part two of our lecture, Mental Health Conditions. Now that we looked at some fun references from Hollywood about anxiety and how that might occur in children, I really wanted to go ahead and move forward with symptoms of anxiety. Now, there's a whole list that has been added here as far as symptoms of anxiety is concerned, but I would like to pay special attention to this particular one, that is inattention and being distracted. Inattention and being distracted being very common to all the age groups that we talked about over here, infants, toddlers, school agers, and teenagers. And in addition to that, we also see some of the additional symptoms such as physical complaints, could be in the form of headaches, stomach ache, or dramatic pain. There's different sleeping patterns. So there's a lot of nighttime awakening, especially for younger children in the age of toddlers and school agers, where they find it difficult to fall asleep. We also see a variation in the eating pattern, where it could be overeating when their symptoms are mild for anxiety, and a child could be engaging in undereating when the symptoms do get severe. And overall avoiding outside activities and social gatherings, not really wanting to be around other individuals, other people. It could be also poor school performances, not really academically performing well. So for example, when you look at the teenagers group, during the junior year, there is a stress and a pressure for performing really well in SAT scores and ACT exams, and all of these other standardized exams that you want to do well in so that you could get into the university or college of your choice. And that puts a lot of stress and anxiety for that individual, especially if there has been a poor performance and you're really trying to come back from that situation. We also see excessive needs for reassurance, especially in younger children. And furthermore, let's go ahead and look at the 4 different types of anxiety. So we have the generalized anxiety disorder, we have separation anxiety disorder, we have obsessive compulsive disorder, social phobia, and we're going to look at all 4 of those in detail. So the generalized anxiety disorder is actually a time where a child experiences excessive worry. Excessive anxiety is often very difficult to control. It could last up until at least 6 months. In fact, that is the identifying criteria, that the anxiety and the worry has to last for 6 months or longer, and that furthermore creating impairment in functioning in the child. It is accompanied by at least one of the following symptoms. It could be a period of restlessness and fatigue. The child is really, really tired, is having a lot of difficulty in concentrating, seems very irritable, not necessarily behaving in their best way or the way that they behave normally, are also experiencing muscle stress, muscle tension, and there's a sleep disturbance pattern that is evident, that is not normal from their regular sleep schedule. And oftentimes what happens, or we see, especially in GAD, the generalized anxiety disorder, is the child strives for perfectionism, and this could be something that is ingrained in them from a younger age, causing them a chronic worry because they are trying to reach that level of perfectionism with everything that they try to achieve in their life, rather it be grades, so having perfect grades, rather it be having a perfect relationship, rather it be looking a perfect way or certain way, whichever way that may be, and constantly reaching that level of perfectionism and not being able to get there will cause a chronic worry. And oftentimes then that worry, if it lasts for 6 months or longer, does start to impact overall functioning and can be diagnosed as generalized anxiety disorder after further investigation. We look at the mean age of onset, that is between 10 to 13 years of age, so we're looking at rather older children and early teens. And then the worry themes that you look at are very common, in a sense that you constantly see the same worry themes for generalized anxiety disorder, and they revolve around, academics, maintaining and sustaining a social life, health and safety of the individual and their family. And a lot of times those worries, those chronic stresses, they revolve around these 3 particular areas. Now let's go ahead and look at, in fact, you know what? I want to give you a very basic example. It could be something that is as simple as making friends, moving to a new home, just like you saw in the previous example within the trailer for the Pixar movie Inside Out, where the child moved to a newer city and was having a little bit of a difficulty adjusting into their new environment, in making friends, in school, and all of that stuff. So when we look at the generalized anxiety disorder, the worry themes is, again, academics, social life, and the health and safety of the individual and the family. Now we're going to look at a second subcategory of anxiety, and that is separation anxiety disorder. This one most commonly occurs, again, among children. And we have two ages where you see separation anxiety disorder spike or could be a possible point of investigation. The first one is during the toddler years when the child could possibly going to attend daycare for the first time. Could be the first time that they are physically being moved away from parent, or mother or father, whoever the primary caretaker may be, is going back to work full time, and the child is in the care of a nanny, and not being in that familiar environment, that familiar face, that causes the anxiety. And then it comes back during the age of 7 to 8 years. During this particular time, especially when the child is a little older, they project aggressive and angry feelings towards the parent, where they're perceiving the new environment that the child is being pushed into by the parent as threatening, and not being able to communicate that feeling with their parents, or with their caretakers. And in this particular situation, the child often worries about, themselves, if they're going to be able to see their parents as often. They're worried about their parents' health and safety. Why exactly is the parent leaving them alone in the care of another individual? They are complaining also of physiological symptoms such as stomach aches, headaches. They may refuse altogether to go to school or play date, especially if it's a rather new transition where the child sees that, okay, mom wakes up, gets me ready for school, drops me to a newer place where they're all new kids, new teachers, I don't know any of them, and then she goes to work. So he or she may refuse that entire event altogether to prevent being moved away from the parent. Now, again, within the separation anxiety disorder, we do see excessive fear and distress when the child is separated from the parent. And I went over some of those reasons of what the child may worry about in the previous slide. The third subcategory of anxiety is obsessive compulsive disorder. It could be a little tricky for you to understand OCD, so I want to divide it into two parts. The first one is to go over what exactly obsessions are, and the second one is what are compulsions. Are defined as scary, bad, unwanted thoughts, impulses, or pictures that really keep coming back over and over to the child. So they're very recurrent, and they take a lot of time on the child's part because they're upsetting, they cause distress, and if they're recurrent, they can even cause impairment of functioning. Now, these compulsive behaviors are often an attempt to reduce obsessive thoughts, and we're going to talk about those. But first of all, let's look into why does it cause stress? Because the child tries to ignore these unwanted thoughts, impulses, or mental images, and when they're really unable to shake them away, those thoughts away, it causes them distress. So not being able to shake away something, right, it causes them distress, and when the child complies by that obsessive thought, he or she then indulges in a compulsive behavior. And again, this is not your regular or your conventional thought. This is something that is completely out of the blue for the child, and that is why it causes them that kind of stress. What could be some of the examples of obsessions? It could be aggressive thoughts, thoughts on contamination, self-doubt, nonsensical thoughts, thoughts and obsessions of hoarding and saving things. It could be symmetry or exactness. It could be even violent thoughts or violent images. Some of these the child could have seen in TV or a commercial, and then they keep coming back over and over. It could be thoughts about sex. It could be thoughts of death and dying. So what is important here is to know that half of the adults who actually had OCD symptoms, they said that their symptoms actually begin during childhood or adolescence. They just never gave it any proper attention, and thus it continued into adulthood. And just like when we talked about, anxiety in general, this particular subset of anxiety, OCD disorder, has a high degree of genetic etiology. What does that mean? It is highly heritable. So if a parent has that, they're very likely to pass it on to their children as well. Now let's look at the second part of this disorder. the compulsions. And compulsions are those repetitive behaviors or the mental acts that the child engages in because they feel compelled to do that in order to stop the discomfort and the anxiety that is caused by the obsessive thoughts. This could be in the form of praying, it could be in the form of counting numbers, it could be in the form of repeating words or a certain pattern of words, it could be remaining silent or counting numbers in silent or inside. Some of the other examples are seeking reassurance over and over, seeking validation over and over, touching or tapping a certain thing over and over, and that particular emotion be a way for the child to alleviate some of that stress that is causing, that is occurring inside internally due to obsessive thoughts. Now, both obsessions and compulsions may occupy more than an hour each day, and that is why it becomes debilitating and starts to impact the child's overall functioning, because it is very time consuming. And overall, it's repetitive and it can be very difficult to control. The third type of anxiety that we're looking at is social phobia, and that is when you have an excessive fear or discomfort of a social situation, especially performance-oriented situations. So they stem from this internal fear of being negatively evaluated and negatively judged by others. Now, I will say social phobia is more common in adults, but we do see a certain degree of that occurring in children, especially those who have extreme amounts of self-doubt, and especially if it occurs during early childhood and does not get taken care of as a child transitions from childhood to adolescence, it may even interfere with school functioning. So even in early childhood, it stems from experiences of rejection, experiences of critical evaluation. Could it be from a parent, could be from a teacher, could be from a social situation as well. And then that leading to this fear of embarrassment in a social situation or during a performance where the child is asked to speak in front of a group or starting a conversation or eating in public and feeling really nervous about any of those situations. You could also add things like reading aloud in front of class, music performances, athletic performances, and the child just feeling lots of discomfort being in those situations. Furthermore, social phobia can actually diminish social skills if it's not treated on time. It can even lengthen the speech latencies, impact the social circle that a child or the adolescent has, limiting their activities, and the child completely refusing an overall social experience such as going to school, which includes engaging with different individuals, with different people, and different situations. So not refusing that and avoiding that completely, that could also be one of the outcomes of social phobia. So again, treatment, recognizing it early and speaking to a healthcare professional and seeking help is the key for the best prognosis. Now we're going to look at a standalone mental health condition such as specific phobia. And in specific phobia, we see a child having a very excessive fear of a particular object or a situation, leading to completely avoiding that feared object or situation, so you never come into contact. For a lot of older adults, you recognize that as being afraid of heights or being afraid of spiders, and there are specific terms to those specific phobias as well. I don't require you to know those. I just want you to know some of the common phobias, and by their common names, like vomiting or going to the dentist, or having a phobia of costume characters. I would definitely look at this list when I'm prepping for, if I were you, when I would prep for exam 2. So I could have a multiple choice question from this particular list. Furthermore, or going back to specific phobia, among children, it is actually expressed through 4 different behaviors, like crying uncontrollably, throwing tantrums, freezing altogether, or clinging on to their parents because they've seen that one item that they have an excessive fear of, or in a situation that they have an excessive fear of. So moving on to panic disorders. And panic disorder is this panic attack that keeps coming back, recurrent panic attacks, or having an intense fear. And during this disorder, the child or the adolescent could experience symptoms of racing heart, heart palpitations, sweating, difficulty breathing, respiratory issues, feeling nauseous, dizzy, having a feeling of numbness, tingling, a fear of dying, really, or losing it altogether. What we do notice that full-blown panic disorders are mostly documented among adolescents, and very rarely do we see them among children. If you do see them, they're usually tied in or cued or triggered by a specific event or stressor. So what I'm saying is out of the blue attacks or out of the blue panic disorders are very rare among children. That sums up what I wanted to share on panic disorder. Let's go ahead and look at depression. So symptoms of depression actually vary in frequency with age and gender, where preschoolers, so what I wanted to do, let's back up a little bit. I wanted to divide the data into three particular groups: preschoolers, prepubertal children, and adolescents. And I wanted to look at the incidence rate of depression for each age group. So for preschoolers, we see still about 0.3% of preschoolers that suffer from symptoms of depression. And for me, even though it's a very small number, less than 1%, it's so interesting because I would want to know why is that number not 0%, right? Especially since classify or identify childhood as a time of not experiencing high responsibilities and really a time period of being carefree. Furthermore, during prepubertal children, during this age group, the incidence rate definitely increases a lot. So it goes up from 0.4% all the way to 3%. So it kind of rotates in between. And for adolescents, it goes from 0.4 to 6.4%. So also see gender variation in depression, where rates do differ between males and females. In fact, rates of depression are actually equal up until adolescence between both the genders. However, they change drastically as they transition out of adolescence into adulthood, where females outnumber the males by about every 2 to 3 cases of females of depression to 1 case per male. Let's look at the causes for depression. Causes could be divided into 2 particular categories. I would like to call them psychosocial and biological. And psychosocial, again, has an environmental component to it, which includes all kinds of life stressors, stressful situations and events that were essentially negative stimuli for the child or the adolescent. And then we have the biological category, which includes suffering from symptoms of depression based on medications, based on endocrine disorders, neurological disorders, all of which can lead to symptoms of depression. So that is included in the biological category. We do see that during the adolescent years, symptoms do increase twice as much. And something that is quite shocking is that lifetime risk of depression for children who had parents who also suffered from depression increases to about 15 to 45%. Now, that seems significantly high, and I understand that. And something to put it into perspective, when you remember the lecture on maternal health and us discussing maternal postpartum depression and how that could increase the likelihood for the child to also suffer from symptoms of depression, that really allows us to see why would this number be high to begin with, and also why preschoolers could be suffering from symptoms of depression. Perhaps the mother was also suffering from PPD and that was not taken care of, and that it got elongated, which then negatively impacted the child. So just to put that out there. Now I also wanted to look at major signs of depression. There are a total of 9 signs for depression that I wanted to share in this lecture. They do make excellent exam questions. I would want to know, if I were you, I would know those. I want to pay special attention to the number 6, which is fatigue or loss of energy. And the reason that this is so important is because this is relevant to each age group. Regardless of the age, every individual experiences a certain amount of fatigue and loss of energy, followed up with a disinterest in things that were fun for them before and are no longer of interest anymore. We also see mood changes, individuals feeling sad or empty by self-report. It could be via observation as well. And then differences in weight gain or weight loss. Now, For older adults, it could be in the form of weight gain, it could be in the form of weight loss. But in children, it's a little trickier. It could even be as simple as failure to making the expected weight gain. So if a child by the age of 4.5 is supposed to weigh 35 pounds, perhaps they weigh 25 pounds. And really using that as a point of investigation to what's going on and why is the child constantly failing to make the expected weight gain. Also, we see differences in sleep patterns, so insomnia versus hypersomnia. Insomnia being not being able to sleep as much or not being able to sleep at all, versus hypersomnia where you have large amounts of sleeps nearly every day. We also see agitation that occurs that is very observable by others. Feelings of worthlessness or guilt, which are often noted among older children and adolescents. Then the inability to concentrate, being extremely indecisive. And then the last one, which is the thoughts of death, suicidal ideation. And this is when you know that the symptoms of depression have really increased to the point where they need to be looked into ASAP. Treatment needs to occur immediately. It could begin with something as simple as, the thoughts of dying. Not a fear of dying, but the thoughts of how would one die. For example, a 3-year-old or a 4-year-old saying how would they want to die. That's definitely a very abnormal thought for that age group. So that could be used as a point of investigation of what exactly is going on deeper down that is causing that thought pattern to come on the surface. In older children or in adolescents, it actually is all the way up into a suicide plan that is developed, or a suicide attempt. So having a very specific plan, and that is also one of the key signs of major depression. When we look at symptoms of depression in children specifically, I wanted to focus on somatic complaints such as headaches, stomach aches, muscle tension, muscle stress causing muscle aches. We also have behavioral problems, and I'm not talking about just being irritable one day and then be normal. It's significant behavioral problems, and often evaluated and observed by those who do come into direct contact with a child very regularly, and them saying that okay, something's definitely very off about the child's behavior lately. The child is feeling very guilty and irritable over very little things, and then that being followed with crying or seeking validation and self-reassurance. In extremer cases, we do see patterns of hallucinations that keep coming and recurring back and forth. Overall, it's very difficult to detect depression than any other childhood behavioral problems, and symptoms that are consistent across age groups are depressed mood, impaired concentration, and suicidal ideation. Now let's talk about the outcomes of depression. And there is a good and bad in there. The good thing is that 2/3 of the patients who do start proper treatment can recover within 1 year, and that's great. That means the prognosis is good. However, the bad part is that the recurrence rate is really high. In fact, it's about 70% within the first 5 years. And there is reasoning for that. Oftentimes, the individual lets go of proper treatment. They check out from the treatment earlier than recommended. They get surrounded with similar kinds of negative, stressful events, negative stimuli that caused the depression to begin with. They start to re-experience perhaps symptoms of depression through similar life experiences, like being in a bad relationship, a bad job, whatever it may be that is allowing them to relive some of the older negative stimuli. Now, we also want to look at comorbidity of depression with other mental health conditions. So within the prepubertal children, we see that 30% of them do become bipolar, and within the adolescents that decreases to about 20%, but still very high, that become bipolar. You do have an increased risk for depression as adulthood, especially if it occurs during childhood, and also if it does remain untreated. So just like with every other mental health condition, treatment is very efficient if it's recognized, if the symptoms are recognized early, and if treatment begins early. And I'm pretty sure you're starting to see a pattern here with all mental health conditions. Now, suicide is the 4th leading cause of death in children from the age of 10 to 15 years. For a little bit of an older age group, between the ages of 15 to 25 years, it's the 3rd leading cause of death. And we do see gender variation within suicide, so rates of suicide attempts versus completed suicide. And it's very interesting because rates of suicide attempts are actually 3 times higher in female adolescents, and rates of completed suicide are 5 times higher in male adolescents. So we do see variation in that pattern here. Now we've summed up symptoms of depression, and I'll go ahead and move on to post-traumatic stress disorder. Again, this is a standalone mental health condition that we'll cover in this lecture today. But post-traumatic stress disorder, or PTSD, it is identified by experiencing significant trauma, and that can be through life episodes, in cases of abuse, extreme neglect, medical illness, an accident, or really any other traumatic experience. And the symptoms include really avoiding and re-experiencing that situation, because the patients, they tend to mentally relive the event. So the goal is to kind of avoid and re-experience that situation over and over and over and over, and it will become seriously disabling if it is persistent, right? If it keeps occurring over and over. The problem is that PTSD gets often complicated if it's comorbid with symptoms of depression, if the individual is engaging in substance abuse, especially common among adolescents and teenagers, or other risky behavior. The good news is that psychotherapy is actually very effective, but then again, you have to recognize it early and you have to initiate treatment early. Now we're going to go ahead and look at ADHD, which is the attention deficit hypersensitivity disorder. As far as epidemiology is concerned, you do see it occurring more commonly in school-age children, so statistically speaking, about 3 to 12% incidence rate. And there's also variation in gender, so it occurs more commonly in boys, about 4 to 9 times more commonly than girls. And the most common diagnosed type is the combined type of ADHD. A little note here about the diagnosis of ADHD in boys and girls. So boys are diagnosed with all subtypes more often than girls, but when girls are diagnosed with ADHD, they are most often diagnosed with the inattentive type of ADHD, and that tells you that we have 2 different types that are going to be covered in this lecture, so pay close attention. Alright, so let's look at the causes of ADHD, and the good and the bad part here is that there are many causes. That's a bad part. So it's really difficult to key to this is the one cause of ADHD, because there are several of them. Another thing is to notice is that ADHD does occur comorbidly with other mental health conditions. In fact, the rate of comorbidity is about 30 to 50%. Some of the factors of ADHD includes genetic. It could be prenatal. It could be perinatal. Perinatal factor specifically is maternal usage of alcohol and drugs, smoking as well. That could lead to development of ADHD for the child. It could also be getting exposure, regular exposure to neurotoxins such as lead too. So even though it may seem like you may not get an exposure with something like that, it used to be pretty common in the past. There are also psychosocial stressors. And again, that includes an environmental component that is based on life events, stressful, negative events, negative stimuli. The thing is that with ADHD, the child must be evaluated for other coexisting conditions, since we do have such a high comorbidity rate with other diagnoses. And psychosocial stressors, if they're not taken care of at time, they can exacerbate or worsen the symptoms. Now let's look at the first type of ADHD that I want to cover in this content, and that is the inattention type ADHD. So it has all kinds of inattention symptoms. To help you remember the symptoms, there is this acronym called Call for Fred that allows you to remember this. I would pay close attention to this particular slide and the one that is about to come, especially memorizing this particular acronym, because it could be on your exam and it makes an excellent exam questions. For example, list 6 of these 9 inattention symptoms of ADHD. If you do remember the acronym, you're easily able to recall those during the time of the exam. In this slide, we're going over the hyperactive impulsive symptoms. So that is the second type of ADHD. And the acronym that I came up with for this one is runs off by the tree. So it's pretty simple to remember. It's easy to remember. So let's go through this one. The R stands for runs off, or is about restless. U for unable to wait for his or her turn. N standing for not being able to play quietly. S standing for staying seated, or it's very difficult for the child to stay seated. O for on the go. F for fidgets with hands or feet. B, blurts out answers. The T of D talks excessively, and the T of tree tends to interrupt. So that sums up ADHD and different issues that were related to ADHD, types of ADHD. Now we're going to go ahead and look at conduct disorder. Conduct disorder is identified with repetitive behaviors that violate the rights of others, whether it be in the family or at the school or in a social setting, and really violating the societal laws with 3 or more of the following in the past 12 months and 1 within the last 6 months. So there is a very specific criteria of how they diagnose conduct disorders among children and adolescents. Some of the very common signs and symptoms are depiction of aggressive thoughts or physical aggression or cruelty to people or animals, destruction of property, older children engaging in theft, skipping school, not attending regularly, so truancy, and running away from home. Just like some of the other mental health conditions that we talked about before, conduct disorder also affects boys more often than girls, so we do see a gender variation as far as incidence rates are concerned. So 12% incidence rate in boys and 7% in girls. We also want to look at a couple of specific types of conduct disorders. So oppositional defiant disorder actually begins during the preschool years when the child is developing a seriously conduct disorder by the time they reach adolescence. And unfortunately, this is the group that has the likelihood of becoming juvenile offenders by 2 to 3 times. The good news is that if the onset of the conduct disorder is during adolescence, that means the child has, behaved rather normal up until middle school, and then all of a sudden these symptoms start to emerge and become very prevalent. This group is actually a much more favorable prognosis, and they're more likely to respond to treatment. So let's look at the psychosocial correlates of conduct disorder. We do see that harsher punishment or usage of harsher punishment during childhood has been the first psychosocial correlate, followed up with institutional living, so living in a orphanage home or a extended care home, or living with grandparents or in different settings, relocating over and over, followed up with inconsistent parental figures, so having several parental role models within your life. It could be in the form of father figure or mother figure, or living with different relatives for years and relocating constantly. So I think institutional living and inconsistent parental figures kind of goes hand in hand, being one psychosocial correlate. Followed up with poor parental monitoring in early childhood and not really exerting those boundaries during childhood and allowing the child to engage in whatever kind of behavior they desired. That really sets a negative example for the child during adulthood, when things definitely will not go the way we want them all the time, and we have to be able to accommodate to situations. And that's what exactly is resiliency all about, right? We also see that parental conflict being one of the psychosocial correlates that negatively impacts children. Could be between, and I mean, there are several different forms of parental conflict. I'm not going to go into all the details in that, but, a very common example, divorce, parents going through a process of divorce and how that transition is like for, children. Maternal depression, postpartum, or just any kind of other depression within the mother, parental alcoholism. So all of those are psychosocial correlates, and that tells you that conduct disorder has a high or a huge psychosocial component, and not necessarily a huge biological component, such as anxiety or depression. The risk factors for conduct disorder, so if the mother does engage in usage of alcohol or drugs during the pregnancy period, it could lead to fetal alcohol syndrome, which increases the chances of ADHD and also conduct disorder. Having the symptoms of ADHD alone also increases the chances of developing conduct disorder. In fact, a child with ADHD or conduct disorder plus conduct disorder is actually more likely to develop an overall antisocial behavior. And if that is not treated on time, it will carry into adulthood. Now, conduct disorder develops as a result of biological risk and childhood experiences. So what I see here is there's an opportunity for early intervention. What I mentioned earlier is that there's a high psychosocial component. That is, the majority of the conduct disorder cases do occur through the psychosocial correlates, but we do have few that occur because of maternal usage of alcohol and drug during the prenatal and the perinatal period. And thus, those are the biological risk factors that puts a child at a high risk of developing conduct disorder down the road. The treatment options, there are several of them. This includes family therapy, behavioral management training, social skills, so within a social setting, rather it be with family, whether it be peers, an academic setting, and really teaching the problem-solving skills at an early age and being able to cope with stress at a young age. All of those have been all of those treatment options have shown significant improvement in patients with conduct disorder, but again, what is the key? The key is to recognize this early and to begin treatment early as well. In this slide, we're going to talk about eating disorders, and we have a full chapter that is dedicated to eating disorders. So I'm not going to go into a lot of details with eating disorder, but I would like to touch upon it since eating disorder, contrary to the popular belief, is actually a mental health condition. It does occur more commonly in adolescents and young adult women, and there are two types of eating disorders, such as bulimia, which is recurrent binge eating and purging, and that is a chronic disorder. It can be relapsing, or anorexia, which has about a 5 to 2% mortality rate. That can be chronic, but it can be lethal as well, especially if the body is constantly in the mode of starvation and there's organ failure and organ shutdown because of anorexia. Just like any other mental health condition, I feel like I'm really being repetitive here, but that is to really say of the significance and the importance of this particular sentence, that early treatment is most effective. Eating disorder also has the treatment is a little bit trickier because there's not just a nutritional aspect to it where you restore the nutrition within the patient or the child and that will resolve the problem. Like I said earlier, it is a mental health condition. So it requires a multidisciplinary treatment approach which has a nutritional component to it, but also, psychotherapy or family education, family therapy, and things like that. All of which, again, a multidisciplinary treatment approach will show that symptoms of eating disorders do get better within the patient with the usage of that. Let's look at substance abuse. I also wanted to touch upon that. I do have a course that I teach that is dedicated to substance abuse, substance prevention and education, taught completely online, HSC 352. However, in this lecture, I wanted to quickly touch upon substance usage and abuse and how that leads to mental health conditions. So the good news is that substance abuse has declined within our youth in the past 15 years. However, substance abuse is often noted to worsen all kinds of psychiatric, mental health conditions, psychiatric disorders, and messes up the treatment protocols. If the child or the patient, adolescent, is doing well for a while and then all of a sudden, does risky behavior, engages into substance abuse, that kind of puts them at ground zero as far as treatment is concerned. We do see this pattern where there's a usage of several drugs at one time that is very common. We also see that drug abuse is associated with often not having strong family relationships and strong parental supervision. So poor family relationships, poor parental supervision. And the treatment is based on improving family relationships and building the child's child and adolescent skill and abilities. So again, it is a multidisciplinary approach as far as treatment is concerned. It does not just require enrolling that adolescent or the teenager in a treatment facility or a rehab, but really engaging them into psychotherapy sessions and other treatment options to make sure that you're providing the best way for them to be able to overcome that substance abuse. Lastly, I wanted to look at bipolar disorder. Bipolar disorder can occur in childhood and adolescence. There are mood fluctuations that are associated with marked irritability, There could be temper outbursts. We definitely see impulsivity as being the key characteristic of bipolar disorder. And the problem is, because some of the symptoms do match with symptoms of depression or symptoms of anxiety, it can be often difficult to diagnose it and treat it because it is chronic and it kind of flares up with life situations. It does occur more frequently in families where there are other members who do exist with bipolar disorder, and that does impact the individual by complicating the treatment protocol. So I've gone over all kinds of mental health conditions that I wanted to cover in today's lecture, and I do have some concluding remarks that I think are of high importance and I want all of you to be aware of. The question is, what is our job as health educators, clinicians, teachers, coaches, healthcare staff? So whatever role or profession you choose to pursue down the road, what will be your job in that profession as far as mental health conditions is concerned, specifically among children and adolescents? But in general, what is your role to play? And I think all of us can play a role in decreasing the stigma of mental health conditions and making it easier to get help. We should all also be big advocates for increasing insurance coverage for mental health illnesses specifically, and to improving access to effective mental health care, especially for the underserved communities and uninsured children and adolescents. It is important to remember that the social and the human cost of not getting treatment are huge and they're life-threatening. It does cost us human life. It does cost us dollars in our healthcare system as well. If you want to look, I want to present both ways for you to look at it. And the best way to remember, or the best way to improve it, would be to improving the human connections, and those are often also the treatment goals. So competence and human connections should be important treatment goals. I do have 2 links for you for additional marked as supplemental materials. These are 2 documentaries. The first one is focused on child neglect, and the second one focuses on adolescents' mental health issues. Now, these are purely for educational purposes, so I'm not planning to include specific statistics or case studies from these videos onto exam, but you do use them to increase your exposure on this topic.